Good afternoon. Thank you so much for joining us. Before we begin, I would like to advise those participating that we will be recording tonight's session. Good evening, all. On behalf of Eastern Melbourne PHN and Banksia Palliative Care, I wish to welcome everyone to the Banksia GP Palliative Care Workshop series, conducting essential conversations with palliative patients and their carers. My name is Nicole Stark, and I'm the Events and Education Coordinator at MFIN. And I'm also joined by Sonia, who is the Palliative Care Program Facilitator here at MFIN. Now, before we begin, I would like to start with an acknowledgement of country. Eastern Melbourne PHN and Banksia Palliative Care acknowledges the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place, and respectfully acknowledges their ancestors and elders past and present. In the spirit of reconciliation, Eastern Melbourne PHN acknowledges the traditional custodians of country throughout Australia and their cultural, environmental, and spiritual connections to land, sea, and community. We pay our respects to their elders, past and present, and extend respect to all Aboriginal and Torres Strait Islander people today. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them, and celebrate their strength and resilience in facing challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. A little bit about Eastern Melbourne PHN. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. MFIN achieves this goal by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. We thank you all in joining us for this valuable information session. This event is an excellent opportunity to enhance your communication skills, gain practical insights with fellow health professionals committed to providing the best possible care for palliative patients and their carers. I'd like to introduce our fabulous speakers. Tonight we have Dr. Chien-Che is a palliative medical specialist consultant in Victoria, working at various hospitals and palliative care services, including Banksia. He also serves as a general practitioner on Saturdays. His mission is to enhance the quality of life for those with incurable diseases. He actively teaches and supervises medical students and trainees to promote academic excellence and compassion in healthcare. Dr. Hossein Kasiri, a palliative medicine specialist in public and private hospitals, focuses on providing equitable, passionate care to patients with life-limiting illnesses. He's dedicated to improving palliative care accessibility and mentoring the next generation of professionals, actively participating in research. His commitment to bettering palliative care is unwavering. Anna Pagnan is the manager of the support and wellbeing team at Banksia Palliative Care. Anna has a Bachelor of Social Work and Human Services. She has 13 years experience working on geriatric evaluation and management unit and for the Aged Care Assessment Service. Anna is passionate about continued education and working with students. On that note, I'll now pass the metaphorical mic to Dr. Hossein.
Okay. Thank you, everyone, and thank you for joining. My name is Hossein, and I know that we have quite limited time, so I might just start with the topic. There are a few number of items that we're going to actually cover in tonight's education session, as you can see. So please make sure you put your questions and concerns on the chat box. We're going to talk about disease trajectory and care, talk about how we can actually make the conversation easier, talk about how we can get informed consent, how important it is about the palliative care and human rights, and talking about advanced care plan and some discussion about terminal phases and how to approach people who are requesting hastened death.
Were you also wanting to share your screen as well?
Are you seeing my screens or
No.
not yet?
No.
Oh, sorry.
Yep.
Excellent. Okay, I wanted to start with this quote from Seneca. If one doesn't know to which port one is sailing, no wind is favorable. It is quite important to recognize that death is an unavoidable part of the cycle of life. Yet many of us do everything we can to avoid accepting our mortality, but coming to terms with the inevitability of death can help teach us to live more fully in the here and now. In fact, consciousness of our mortality can enable us to cherish every moment of life that we have. The first aspect is to recognize when palliative care should be considered. Palliative care, as you know, is targeted towards people living with a life-limiting illness. That includes people living with an active, progressive, advanced disease who have little or no prospect of cure and who are expected to die. So historically, it was assumed that palliative care would commence only once all the treatment aimed at curing people has finished, as you can see on the left-hand side. But now it is well accepted that there is a benefit in providing palliative care in association with disease-modifying therapies that aim to prolong life. So they can go hand in hand. And before jumping into talking about how to discuss about the illness, it's important to understand that most illnesses follow one of the typical illness trajectories, as you can see here. So the one on the top left-hand side, it's a short period of evident decline. So in here, there is a long maintenance of good function, which may be followed by a few weeks or months of rapid decline prior to the death. And most reduction in function occurs in the person's last few months of life. We see this pattern in patients with most malignancies. On the right top hand side, there's a long-term limitation with intermittent serious episodes in which there is a gradual decline in function, but it's interrupted by episodes of acute deterioration. And while there is a risk of dying during each of these acute episodes, the person might still survive. So it can be quite difficult to know when the person is going to die. We see this pattern in patients with chronic diseases such as COPD, heart failure, renal failure. And the one in the bottom is the prolonged gradual decline, in which there is a long-term progressive disability, and we see reduction in the function of the person. But the death may follow other events, such as the person might end up having an infection, might have a fall, or might end up having a fracture, more debilitated, and end up with becoming bedbound and get illnesses related to that. And we see this pattern in patients with dementia and frailty. It's a quite common pattern. So when we care for a person with multiple severe or end-stage comorbidities, or if they have frailty, it is quite important to have a good understanding of which therapy provides benefit and which may cause more harm. And the duty of the healthcare provider, like us, is to mitigate suffering. So as Gordon said, it is important to remember to cure sometimes, to relieve often, and to comfort always. And further to that, death should be recognized as a natural culmination of life. Care providers have the primary duty to improve quality of life all through life, which includes the dying phase. So in the life-limiting situations, the focus of care shifts from a curative intent to those that can actually improve quality of life. So how do you engage with patients and families who request treatments that is not medically appropriate, or there might be conflicts between family members, perhaps including the patient even and the family, on the level of therapy that they require? You might have heard some of these quotes saying that we want everything done. There must be more treatment that he can have. Should he not be in hospital for antibiotic and IV drips? Can he have at least some IV or subcut fluids? I might here open up to Dr. Chien and Anna to see how they would actually respond to these comments or questions. How do you actually assist the patient or the carer to mitigate the suffering during this time?
Thanks, Hossein. Yeah, these are very common questions. I'm sure a lot of the attendees in the would have been confronted with a lot of these questions as well. And really is we're in a situation where we're fortunate that we can access so many treatments, but also in a situation where because they have worked so many times in the past that people really have problem to see how they might not be effective anymore. Plus also that perhaps if they spend time on these treatments, they're not able to spend time on other care that and spending time with their family at home. And I think it's right the redirection of and reminding people that, well, this might be the time may be short either way, and whether they want to spend time having treatments or they want to actually spend this at home and with their loved ones, and not pursuing potentially futile but also potentially high burden choices. And Anna, do you want to?
Yeah. I think you mentioned something, Hossein, about, sometimes families also want things that the person themselves who is dying doesn't agree with. And so I think there's also an opportunity there to have a discussion about what the person who is dying wants, and really kind of support the family with that as well, because it can be quite devastating for family to know that their loved one is dying. They don't want them to be in pain. They think that if they don't have antibiotics, you're killing them, and those sorts of things. So I think it's important to kind of, I think, have a bit of empathy and compassion and really try and have these discussions with them. And I think that even though they can be difficult discussions to have, often once you've had that discussion, there's such a relief from the family and the person who is dying, because they're things that they haven't been able to say, and you've just kind of brought that discussion to light and to the forefront, and they're having these conversations that they've not actually had with each other, because lots of people don't talk about death.
Thank you. Yeah, I think in summary, it's, as you all mentioned, it's about communication. So knowing some communication skills, showing empathy, and as you said, actually people want to know, and it's quite important. So we mostly physicians or healthcare providers we're generally trained to maintain health and fight illness, but typically receive little guidance on how to communicate with dying patients and their families. I just want to open a quote here to say that when we talk about dying people, actually, it doesn't mean that they're just dying in front of us. It can be days, weeks, and months. So, so in our death-aware society, it's not surprising that many physicians find it difficult to engage in difficult discussions. This has been regarded as almost equal to medical failure, which implies that physicians have nothing to offer. A physician must recognize that quite contrary is true. Good communication can help reduce fears, minimize pain and suffering, can enable patients and the family to experience a peaceful journey of illness and even death. A large majority of patients are interested in discussing end-of-life care and with their physicians. So most believe that physicians should introduce the topic. So physicians must accept the responsibility to initiate timely dialogue, as many patients will wait for the physician to raise the subject. So discussions that and it's important to know that discussions that focuses only on resuscitation often fail to recognize important physical and psychosocial concerns of the person and family. Here, I've put some examples of some topics that quite important to address when you're having essential conversation, like journey mapping. Journey mapping means that where they are actually in the journey of illness. And if you have listened actually to a podcast, it's called Waiting Room Revolution. They talk about actually journey of illness quite interestingly. And one of the metaphoric actually example is about someone who is pregnant. And you say, okay, where am I in my journey of pregnancy? It's the same thing. It's the same. I mean, it's different, but journey mapping is the same thing. Okay, you're in the second trimester, you're in the third trimester. Okay, you've had second line of treatment, you've had third line of treatment. Is there any more treatment available? Your performance is improving, so you can have further treatment, or your performance status is declining, we can't offer you any further treatment. So it's quite important to actually map it for the person so they can understand where they are. Talk about treatment options, talk about treatment limitations, talk about prognosis, identify the fears, the worries. If they've got any unfinished affairs, talk about preferred place of care and death, and advanced care plan, and appointing medical treatment decision maker. You might name some other more, but these are some of the examples that could be important to discuss. And another important, quite interesting thing is that during our training, we're often taught to address resuscitation status with language similar to this that you can see. I'm not going to read it out, but quite actually typical. Okay, I'm going to talk about your resuscitation. If your heart stops, you want us to jump on your chest. If your breathing stops, do you want to put a tube down your throat to continue with the machine and attach you to a machine? Yes, no. What is lacking in this typical discussion? Although this warning is quite familiar, it's woefully inadequate. So first of all, it lacks empathy. So it limits the patient-physician alliance. And it doesn't address prognosis. So patient may request CPR with unrealistic expectations when they don't know how the prognosis is. And inappropriately, it emphasizes on those interventions that you're not going to offer and ignoring those treatments or interventions that you could actually offer. So if you're not offering anything, you just, the patient might feel abandoned, that, okay, I'm here for some help and you're not offering anything to me. And finally, all the burden of decision-making is pushed onto the patient and the family, and the physician provides no guidance in addressing these complicated issues. I've got a very simple, pragmatic 4-step approach to discuss essential conversation in a patient with life-limiting illness. So we should start with discussing in a sensitive way, obviously. So to create a forum for ongoing dialogue. And then it needs to be followed by clarifying prognosis, then talking about end-of-life goals, and finally develop a treatment plan. So every step provides a necessary foundation for the further discussion. And if we feel like, okay, we're now talking about the goals, it doesn't actually match with the illness, maybe we need to step back and talk about prognosis and then come back again. As the illness progresses, the patient's hopes and fear can change. I'll give a very quick example. So someone comes to your clinic and say, okay, I've had some GI bleeds, and you organize some tests. The patient goes home and says, well, okay, I hope this is just a hemorrhoid. It will just go away by itself. The patient goes say, oh, okay, now it's a little serious. You need to do colonoscopy. You organize colonoscopy. The patient feels like, oh, okay, I hope it's just some polyps. It would be okay. And then it comes back, it's a cancer. Patient hopes is that, oh, okay, I hope I can have treatment. They offer surgery. So, oh, okay, I hope that everything goes away. I don't need to have a stoma. So, well, you need to have a chemotherapy after that. Oh, okay, I hope that I can tolerate it better. Over time, disease can progress. So, well, okay, I hope the treatment can initially was about cure, and then the patient will think that, oh, okay, I hope I can live a little bit longer. So as you can see, actually the hope evolves, the fears changes. When the person said, well, okay, there's no treatment, still they would hope that, okay, whatever time I've got left, I hope I have painless journey. And at the end, as the death nears, the person would feel like, oh, okay, I hope that my family can continue seeing each other after I die. So it just changes. And as the illness progresses, the physician is challenged to respond to the pain and fear a patient and the family are experiencing. So in this context, Emmanuel talks about fearless healing. So to heal, one must witness pain without fear. Healers can hear pain. Healers give people permission to show pain, and healers are not afraid to see pain. And fearless healing can mean initiating an end-of-life discussion with a terminally ill person or discussing a worsening prognosis. So you can see here, it says, I know this is a very difficult time for you and your family. You have never been this sick before, and I know that it must be frightening to you. I want you to know that as bad as it is, we will deal with it together. And sometimes fearless healing means listening to a person talk about the physical decline, talking about the emotional, spiritual suffering. While I can't cure you, there are still many things I can do for you. I want you to be able to speak openly with me so I can best help you. No matter what happens, I can be here for you. You're not alone. And it's important to actually ask probing question. Okay, you told me that you don't want to suffer. What type of suffering are you talking about? You said that you don't want to be a burden to your family. What does that mean to you? You said that you don't want to be kept alive as a vegetable. What do you mean by that? So these are the things you just need to ask a little bit more question to dig further. And in here, you can also clarify patients' wishes. The preferences of terminally ill patients, as I said, trends towards less aggressive care as the illness progresses. So most patients believe that at some point, life-prolonging intervention should be limited. So we can support this important notion by asking, are there any treatments that you might not want to receive? And there's a natural inclination to use ambiguous language when we discuss bad news, to downplay the seriousness of the patient's condition. So when there is no therapeutic options available, the physicians must acknowledge this with directness and compassion. So there must be no chance for any misunderstanding. So when terminal ill persons are not fully aware of the prognosis, then they tend to overestimate the survival, which again makes them actually request some medical treatment that you might feel like not appropriate. And patients and families often require repeated explanation in order to understand a medical problem. Repetition enhances the comprehension. And also remember, during times of high anxiety, concentration and comprehension might be further limited. It's quite helpful to actually check the patient's understanding quite often. In terms of clarifying prognosis, I hear this actually phrase frequently that is said to the patient and the family, that we don't have a crystal ball. It is true that we don't have a crystal ball, but you don't need a crystal ball to estimate prognosis and discuss it. We as doctors and healthcare professionals, nurses, have seen enough patients with similar conditions, so can tell them where they are in the journey of the illness. As I said, metaphorically, like with the pregnancy example. So if someone comes in with some symptoms of pregnancy, you do the test and say, okay, you're pregnant. And the patient says, oh, okay, so what is going to happen to me? And you tell them, okay, oh, okay, I don't have a crystal ball. I don't know what's going to happen to you. Some people might have the healthy child. Some people might have a stillbirth. Some people might die, or some people might not die. I don't know. So the patient gets confused. So you need to actually have something to say that, okay, majority of people actually go through a 9 months pregnancy. Sometimes it comes a bit earlier, sometimes a bit later. You don't need to overwhelm the patient at the beginning with lots of information, but they need to know that, okay, this is the journey, this is the beginning, this is the end, where they are. Okay, your first trimester, do this test, we're doing it together. Some people want to know more, they go and read a bit more about it, but they need to have, some people want to, some other people may not want to know, okay, what's next? And that's okay. We just need to make sure that we can actually continue communicating either with the patient or with someone they have actually nominated. And prognostic discussions are bounded by epidemiologic shortcomings. Statistics speak for groups, not for individuals. Should we focus on the small number of patients who outlive the average, or those who follow the usual course? Can we be a source of both truth and hope to our patients? So this one says, this quote, most people with multiple myeloma who are at your stage of disease continue to do very well for 3 to 5 years, but that is the average patient. I cannot predict exactly how you will do. I certainly hope that you will do better than average, but it is also possible that you may do worse. In this way, you can help patients to walk in two roads. And again, this is something I've heard from actually that podcast, Waiting Room Revolution, where they actually talk about walking two roads. You might have heard about it. So it means that actually, while hoping for the best outcome, at the same time, have planned for what if things do not go as we planned? What if things don't go as we expect? So you're not actually surprised or shocked. And once the patient and family acknowledges that death is approaching, the physician's role is to facilitate an open discussion about desired medical care and remaining life goals. So the quote says, as a doctor, I want to make sure we are always doing the things that might help you, and that we never do anything that either can't help you or you wouldn't want. So need to know what things are most important to you. Given your illness, how do you want to spend your remaining time? And as the death nears, most patients share similar goals. They want to maximize the time with the family and friends, avoiding any hospitalization, unnecessary procedures. They want to maintain the functionality and reduce the pain or other symptoms. Some patients have special requests, such as important visits. They have desired conversations. They wish to involve hospice or some religious counsel in the final care, or see the priest or pastoral care. And then when the death is imminent, the decision is more limited in the scope. As you can see in the last quote says, when people get to this stage, some people feel like they want to keep fighting, And other people feel like they just want to be comfortable and let things happen as they may. How are you feeling now? So it just makes it quite actually open for them, and it makes it okay for them to feel either way, because some people feel this way, some people feel the other way, and it's okay to feel either way. And occasionally a patient or family would say that they want everything done to prolong their life, regardless of the prognosis. Some people will say, I know my children wouldn't want me to give up. I have to keep going for them. Again, I might open up to Chien and Anna to see how you would tackle this sort of like a not uncommon sort of like a conversations.
Did you want to go, or do you want me to?
Do you want to go first this time?
So I think with the, the comment of, my children wouldn't want me to give up, I think it offers a good opportunity to ask them, what their view of giving up actually looks like. If they're already sick and, they are dying, are they actually giving up, really? So I think it's about your third point there about understanding the motivation and why they are saying things like, I need to keep fighting and I want everything done to prolong life. I think understanding what is actually underlying that and having a conversation about that with them is really important. Yeah.
I completely agree, and really understanding what life means to them as well. Saying that there are sometimes really unrealistic expectations and also a perception of life, and there are people who do believe any signs of life is worth preserving, and that's something where we need to then have a deeper conversation about the quality and social meanings of their current condition, and going through that. But yes, I think exploring more is definitely the key here.
Absolutely, thank you. So as everyone said, it just going back again, one step back to say that, okay, where we are with the journey of illness, prognosis, and then what life means to you, what they have actually dedicated, what makes them proud of as a person in their life. And sometimes it's about actually they need to re-image what is important for them, find a new value for living and what is important for them during that limited time. And often patients look to the physicians for guidance. So it's doctor's responsibility to develop that treatment plan. So the quote says, from what you've said, let me suggest the following plan. Please tell me if I'm correctly representing your views, given that being at home and spending time with your grandchildren are most important to you. That is what we will focus on. We can organize your radiation treatments as an outpatient basis. I can also arrange to have visiting nurses see you at home as needed. Let's make sure that we design your medical care so that you can accomplish what you want with your remaining time. And that's actually talking about the patient. It's all about the patient, what they want, what they find it actually quite important for them. Spending more time at home, spending more time with their loved one, if they have actually expressed that previously. And it's important, again, preferences regarding resuscitation should be clarified, and not just resuscitation, about actually specific treatment. Do they want life-prolonging treatments, intervention? Do they want for that intervention to go to hospital? For example, for people actually who are who reside at residential facilities, do they prefer to actually receive care at their home, or do they want that to be escalated further to present to hospital? And if resuscitation or treatment limitation hasn't been addressed, it's quite, again, important to actually discuss that. And our role is to make sure that patients appreciate the limitation of CPR to make an informed decision regarding its use. It's quite interesting. Most people gained at least some of the knowledge about CPR from TV or TV shows where the majority of resuscitation attempts are successful. So patients frequently overestimate the utility of CPR and are particularly unaware of poor outcomes for the chronically ill people. So patients need to know that the likelihood of survival is related directly to one's underlying illness. And with patients in the terminal stages of chronic illness, CPR is rarely, if ever, successful in prolonging meaningful life. I let the audience actually to read the quotes. Okay. So the definition of palliative care is that it's a person and family-centered care. So, and it's important to make sure the family members also understand the situation. And as the inevitable death nears, family members must understand that aggressive intervention changes only the time and condition of death, but not the patient's ultimate fate. And in these circumstances, foregoing aggressive resuscitation allows for a more comfortable and humane death and represents an act of love, not one of abandonment. Okay, we talked about 4 steps approach to the conducting actually essential conversation. Now we got some time for discuss more topics. One of the topics is about informed decision making in this area. You might have heard some of these quotes to say that, oh, please don't tell my dad that he has cancer. Don't tell my mother that you're from palliative care. I might just go back to Chien and Anna. Chien, I might start with you. How would you actually respond to these quotes?
So I'm actually pretty practical, very accepting of our involvement and happy to have more thing. I actually might not push further, but but actually it's always important to check, because one, they might already know, and there's a lot of assumptions or mutual pretense, I think is a term often applied here. The other thing, of course, is that I do probably do a bit of disclaimer that, no, look, I can't lie. Like if they do ask me about it, I'm not going to lie about where I'm, what service I'm working with, and in terms of what diagnosis that we are working with. But I will signpost in that I would check that the person do want to know, and often take several steps saying, do you want to know even if it's bad? And I also offer them a chance of, do you want your family to be here when I'm talking about this? So yes, lots of signposting, but reassuring the family that, I wouldn't just blurt out a really bad news without any setup.
I think for me, from a social work perspective, I would really like to know why they don't want their family member to know that they're dying, or that we're from palliative care, because that will indicate that they may be dying. Often it's they just don't want to see their loved one, I think, fear death, or it's their own fear of losing their parent or loved one that really makes them feel like, well, I need to deal with this. I can't deal with mum or dad's reaction to this and my own reaction to this. And so I think you know, as we've been talking about, the whole presentation has been about communication, and it's really about helping people to understand where that fear is being driven from, and hopefully having discussions so that, you know, if that person wants to know what's going on, it's their life. They actually have that right to know what's going on for them. So I think it's again about having those discussions and figuring out where that drive is coming from.
Thank you. Yeah, I guess in talking about actually the right, you're right. So because they have to actually to make the decision what they want about the future, about the treatment or not having treatment. So according to Department of Health Victoria and Medical Treatment Decision Making Act 2016, all adults have capacity to make decisions unless medically challenged. So a person with the decision-making capacity has the right to refuse medical treatment, but they need to actually be informed first to accept or refuse it. So it cannot be actually done by someone else. But because it's a holistic care, family play a huge role in someone with terminally ill condition. So we need to respect that the whole situation, but in a very sensible process, as was discussed. So practitioners should obtain informed consent prior to providing routine care. So talking about routine care, however, you do not require informed consent to provide palliative care if a patient is unable to give consent. And it's important to understand that medical treatment decision maker or next of kin cannot refuse palliative care for someone who is not able to communicate. And it's the same thing as I just said. It's a part of the Medical Treatment Planning and Decision Making Act 2016 that talks about the medical practitioner does not require a person's consent if it's going to save life, if it's going to prevent them from serious damage from the health condition, and also to provide palliative care. And as per World Health Organization statement, palliative care is explicitly recognized under the human right to health. It should be provided through person-centered and integrated health services that pay special attention to the specific needs and preferences of individuals. Other challenging codes that we see every now and then is just talking about you're just starving or dehydrating, or you're killing him with morphine. Again, talking about a little bit of like a human rights. I might just open up to Anna to start with. How would you actually respond?
So I think often people are concerned that, well, one of the things that I come across a lot, well, both of these things. So they're concerned that their loved one is starving. And so I do think that, again, it comes back to having some sort of education about what happens to the body when death is sort of, coming, imminently. And that, the appetite goes, the want for food goes, those sorts of things. And I think it's about really finding out, so they're worried that they're going to starve. So let's give them the information that they need to alleviate that fear. They don't want to think of their parents starving, for example. The morphine one is a really tricky one because I feel like a lot of people feel like they don't want to take morphine. They're in pain. Oh, we don't want him to have that because it's going to kill him. Oh, he doesn't want that because, So, that's a really tricky one again. But again, it sort of comes back to the same thing about education. And being able to really, I think, connect with these people, knowing that the motivation behind these, thoughts that they're having and sometimes requests that we think are a little bit kind of, out there. It's always to do with love for the person that they're caring for. And most of the time what they need is the empathy and education to sort of carry them through that.
Thanks so much, Anna. And yeah, agree with all that. And that really just a very quick sort of personal approach to add on. I often talk about how, they're not eating as the result of the body slowing down, and it's not the cause of the body slowing down. So they're not starving to death, but rather they're not hungry and not needing the food. And in fact, I allude to, even if we put the food into the veins or into the stomach with tubes, and we know that they don't help and often cause more problems. And that, yes, absolutely, the medication, they're there for pain. They don't do anything else. And if pain is limiting the person to have a comfortable sleep or have other sort of or do anything activity of daily living that they can still do, then it's absolutely better to manage the pain. And yeah, it's very, very hard to manage cancer pain without morphine.
Thank you. I guess that was quite important, the education, as Anna said. So I think also, as Anna alluded, it's important actually to not dismiss that love, dismiss that passion that is actually family providing. So if someone actually doesn't ask, it doesn't mean that they don't have love, they're not providing love. It's just sometimes people actually express it in different ways. So telling the family that, okay, once there are things that people actually would lose as they're dying. So they will lose that, they will become social withdrawn. They would actually lose their interest in food. And we've had actually some people that bring food and they're quite upset because the husband actually loved the food that the wife cooked for years. Now they're just not looking at it. It can be quite actually heartbreaking for that wife. So they just need that information and education. And some of the actually other quotes that we might actually hear every now and then as the in the terminal phases, that is this person actually suffocating, choking, and they want to get out of bed, they're in a lot of pain. What should we do? Should we actually give now more morphine to actually to shorten this? I guess I might ask Chien, how would you actually approach?
Yeah, so I think explaining the common changes in the terminal phase is, I think, extremely high yield for health professionals to know about and to reassure the general public. Because I do think a lot of people come back and say, oh, my family member just drowned in their secretions at the end, and that's such a common bereavement comment that I think it is everyone's role to explain it clearly. That if the breathing change is secondary to losing consciousness, then we do not think it's distressing, and that's different to, of course, someone like with motor neuron disease, for example, and who has secretions or other breathing changes prior to losing consciousness, and it's very different. But the majority of the time, if the breathing changes came after they've lost consciousness, then we don't think it's distressing. I often use the analogy of it. It is like snoring, even though there's a few different other things going on, but it is just in principle like snoring, where a person's lost consciousness, therefore they can't control their breathing, and it's getting louder, slower, faster, either way. The discussion about delirium and potentially agitation is also important, only because we see so much that people just use pain relief and to manage agitation. And the thing is that opioids are not reliable sedatives, and in fact are more likely to drive delirium more so than antipsychotics and benzodiazepines, which is why it's so important to recognize agitation where we can. And of course, pain may be part of it, but it's also important to make sure that if we have options, then morphine may not be the actual drug of choice and management of choice. And the last option really about repositioning the person, and it is that again, it comes back to talking about skin care, pressure area care, and other sort of personal hygiene care. And in a sense, it's not black and white. And it is not uncommon that people do need pre-care medications so they can be comfortably cared for, and partially because of the delirium, partially because of potentially actual painful conditions. But yes, sometimes we do recognize we may need to reduce the amount of time of repositioning as well. And finding that balance case by case is very important, and letting the family know that we have heard them and work out a good case by case individual approach.
Thank you. I might just hand over to Anna here to talk about advanced care planning, if that's okay, Anna.
So this is a nice little quote, a letter to my future doctor, which really is a nice way of thinking about advanced care planning. So if you want to skip slides, yeah, that'd be good. So there's three main parts to advanced care planning. The form sort of goes through, personal information. Then there's a section where you fill out values, things that are really important to you. And then there's the instructional side of it, which is where, you can say what type of healthcare treatments you would want or that you wouldn't want to have as your, when it comes to a stage that you may not be able to articulate that, so that your family, medical professionals, people know what was actually important to you and what you would have liked your end of life to look like, basically. So it can be about, it can be things like being pain-free. It can be about who you want in the room with you when you die. It can cover a whole range of different things. And it's a really handy thing for people to have, so that, at the end of the day, we can try and make sure that we are staying true to what that person would have wanted for themselves. The advanced care plan comes with like an instructional booklet that you can go through. And basically at the end of the document, once the person has filled it out, it needs to be signed, and that makes it a legal document, basically. So if there's something in there that the person has written that they don't want to happen, and that treatment cannot be given because that person has stated that it's not something that they would want to occur, basically. And then there's the option of appointing a medical treatment decision maker, which is appointing someone that the person trusts to make sure that their wishes are carried out, basically, if and when they're unable to articulate what they want in the future. Do you want to tap the slide for me? Thanks. So I don't know if I've kind of gone over this a little bit, but basically what I just said, if there's an advanced care directive, whatever's in there is legally binding, given it's been signed by someone who has capacity and it's been co-signed by a medical professional, or I think a psychologist who has gone through it with them, to make sure that they understand, what they're saying in that document, basically. And this kind of goes over some of the consent things that Hossein was speaking about before. So you can probably tap. And is this back to you? Yeah.
Yes, thank you. I guess one thing, thank you, and I wanted to add to that is that the instructive directive section, you make a legally binding statement directed your health practitioner in which you consent to or you refuse a specific future medical treatment. If someone actually put illegal, it doesn't mean that the doctors should actually follow. So it's only doctors will follow what is medically appropriate and to what is actually legal. Another challenging topic is how to respond to a request for hastened death. Chien, do you want to actually go through this? People actually would say that, okay, this is not life. You wouldn't do this to your dog, and can this happen sooner? I just want to just sleep and not wake up. Can give me my morphine so I can actually kill me with morphine. How would you actually respond?
So it's important to recognize, one, this is desire to die and wish to hasten death are common, and there are difficult situations to walk into. They're often a flag for distress, and they require immediate attention and a holistic response to it. In terms of in terms of values of life, it really is defined differently and individually, and very important to make sure we respect all the meanings of life to the person and to the caregivers as well. And look, my personal pet thing, of course, is that with animals, we don't necessarily ask them how they're feeling themselves through these type of situations. We just do things to animals, and but we shouldn't be doing things to humans without knowing what their values and their understandings are, and it is important to do things with our patients and not to our patients.
And have you encountered such? I guess you have. What's your? Do you have any approach how to actually respond in general?
I think I think the making it end sooner and wishing that they would just go to sleep and not wake up is quite I've heard quite a bit. I think it's unpacking it really, and talking to them about it's coming from somewhere, like Chien said, so it's sort of is it because they're distressed at seeing the loved one in pain, or because the person is actually in pain? Maybe they're just tired of it. I think sometimes these things, yes, they need attention and it is important to address it, but I also think that in some ways they're sort of normal things that people can think when you're sort of coming to the end, but it's sort of taking longer than you're prepared to sort of hang on for, I think. So I think that it's important to just have those discussions with people and provide as much reassurance as you can and care and support, really.
Thank you. Yeah, as you both said, the motivation for this request is quite actually a big interest for us, and we just want to know that, okay, do you have a lot of symptoms? Do they have a concern about progressive debility? Is this a combination of loss of sense of the self, loss of control, fear of the future, or fear of being a burden to other people? Can also actually make them feel like, okay, I'd rather be dead. And the first comment here is that opioid and benzos are not reliable lethal agents, and it's illegal, to be honest, so to do that. So, and it's all talking about, as we said, a healer. So a healer should not be fearful of hearing the people's actually fear. So some physicians are frightened to these requests, feeling that they are being asked to cross unacceptable professional boundaries, and some others might be tempted to quickly exceed in imagining that they would want same thing in their patient's shoes. But requests for a hastened death may provide some awareness of a patient's experience of suffering. So there's something behind it that we need to explore, and clarifying this question that it's quite important. What is it that they're asking from us? So we need to actually explore further to understand what is behind that request. And I'd like to emphasize here that I wasn't specifically we weren't talking about the request for volunteer assisted dying. And as per Palliative Care Victoria, volunteer assisted dying is not part of palliative care services. And if a palliative care health professionals or organization choose to offer or provide volunteer assisted dying for the patients with life-limiting illness, this is their practice, and it's separate from palliative care. And you can see the statement from Banksia Palliative Care Service there as well. So these are the topic that we covered. I understand it's 8 o'clock. We 1 minute past 8, and I might just hand it to. Okay, I have to check actually. I'm handing to Crystal. Yep, thank you. We'll take it over to share the healthcare pathway.
Fantastic. Thank you so much. It's a bit tricky to get through all of that information in such a short time. It's a huge topic.
I'll just get you to stop sharing your screen as well, please. Thank you. Yep, can see.
Okay, thank you. Okay, welcome. I'm just going to do a really quick one overview here. Okay. Okay, welcome to Health Pathways. Health Pathways is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website to access comprehensive collection of locally relevant clinical information and guidelines, designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will hopefully demonstrate how to access and navigate health pathways to find relevant pathways specific to having essential conversations in palliative care. Navigating is at the Health Pathways website and log on. You can search for the relevant pathway by using the search bar at the top or the left-hand side. Table of contents. There are over 40 pages in the palliative care suite. You can select the pathway that matches your search. As you can see, this is a resource page. I'm going through it quite quickly here, but it's to provide a concise overview of palliative care, care coordination, specialist support services. There are drop boxes throughout which provide additional information and links. Here we've gone out to the advanced care planning page, which is also a resource page. You'll find a succinct list of steps that clinicians may wish to consider and includes links to key documents involved in the process. We've got a lot on consent, advice and assistance, and you've also got a link to see all of the forms and documents that may be required. The information section at the bottom of the pathway provides a selective list of useful links of information specific to health professionals and the patient. As previously mentioned, there are 40 palliative care pages available on Health Pathways, which include clinical, referral, and resource pages. This slide provides a list of relevant and related pathways for essential conversations, including palliative care overview, GP resources, advanced care planning, resources for bereavement, loss, carer wellbeing, and also the legal and ethical resources. Continuing on with the palliative care suite, this slide will provide a list of other relevant pathways: symptom control, local community palliative care providers, palliative care medications, emergencies in palliative care, and palliative care referrals. To access Health Pathways Melbourne, go to the website address melbourne.healthpathways.org.au. It's available to general practice teams and other clinicians in the Eastern Melbourne and Northwestern Melbourne PHN catchments. If you don't have access yet, you can click on register, which brings up an online form. We can also organise automatic login so you can access Health Pathways without a username or password. Just email the team at Health Pathways, or you can register via the QR code. Thank you so much, and hopefully that's been beneficial.
Thank you very much. So I think it's back to me to go through Q&A, which there's none typed in the box. Hopefully it's not because there's some IT issues. But yes, I know we are also a bit over time as well, which is great. So if there's any questions, please feel free to email us afterwards. There will be a post-session email sent out, so please feel free to email us, but also just call. So if you're in the Banksia catchment, please just give us a call. So we're 3 LGAs, so we're Shire of Whittlesea and Nillumbik, or the city of Banyule. And but also, if you're not in the Banksia catchment, go onto Palliative Victoria website and find the service provider near you. We're still happy to take your calls, but also call the other community healthcare services and get to know them. So I'll hand back to Nicole. Oh, there's a question in there. Actually, so very quickly.
I just saw the question, yep.
Yes. So just wondering, which do you think is the best to use first-line medication for pain or agitation if you're not sure? So my personal approach is that one is understanding is sedatives actually do work on pain. So painkillers, so opioids, the aim is to relieve pain without sedating the person. So if you're sedating the person, they actually do, you do reduce their awareness or relieve their pain, which is why a lot of the sedatives, in fact, have analgesic properties. So benzodiazepines often are, as you know, are often used for back pain. Not that they because people build up tolerance quicker and they're more likely to be sedated. So, we should use non-sedating analgesics first. So sedatives probably are more useful in that sense. The way I try to tell is I think pain is often more limiting. So people are often the type of thing that causes pain are often more sore when people move around. Whereas saying that, though, of course, we know renal colic or retroperitoneal pain can make people move around for sure. But a lot of bone pains, they're worse when they're moved. Whereas agitation, of course, people are moving around. So and that's what I explained to the caregivers and in terms of choice of medication. So sorry, Nicole.
Thank you so much. And thank you all for being part of tonight's session. It has been an absolute pleasure to have you all here this evening. And I hope you've taken away some valuable insights. I'd like to extend a special thank you to our exceptional presenters for their fabulous work. By participating in tonight's RACGP accredited activity, you will receive 1 hour in educational activities. And I will lodge those hours through the RACGP on your behalf. At the end of this session, a link to the workshop survey will appear on your screen. Please do take a moment to fill in the survey for your accreditation and to provide some valuable feedback so that we can further improve these education workshops. Your responses are greatly appreciated. This is a 5-part palliative care in the community series, and if you haven't already done so, please register yourself for the next session. The role of the GP in prescribing opioids for palliative care patients. It is being held on Zoom again. It'll be Thursday, the 2nd of November from 7 p.m. to 8 p.m. It is another RACGP accredited session, and you can scan the 3rd QR code to register yourself for this virtual activity. Please also take a moment to check out other upcoming MFin education events by scanning the middle QR code on your screen, and it will take you directly to our events page on the MFin website, where you will be able to find out more information about what other education workshops we have coming up and to register yourself for one. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources. You will also receive your certificate within the next 4 weeks from this session from MFIM. Thank you all for joining. Thank you all for your time this evening and your attention. That is all from us, and have a wonderful rest of your night. Thank you all.